I wanted to give you a handout too when you go home, so I think you have these, because if anyone has come to my office, they know that I'm a huge advocate of non-pharmaceuticals, non-pharmacy nutraceuticals for your health. So I'm going to give you 3 handouts, and I write this down for patients. If you have a cardiac history, one of my favorite cardiologists recommends these over-the-counter supplements: magnesium, CoQ10, D-ribose, L-carnitine. They don't treat the symptoms of heart failure or heart disease. They just provide supplements that help the energy systems of your heart pump better and get rid of the fluid. So it's kind of a way that's, that helps you get rid of fluid without giving diuretics. Anti-inflammatories are wonderful, but there's no free lunch. They have an effect on your kidney, on your stomach. If you take them long enough, they can cause some other issues. Here's 20 different natural anti-inflammatories. I've highlighted the top 3 of my list, and you'll have these on your handout: omega-3s, turmeric, baby aspirin. And we don't worry about bleeding as much as we do clotting, because a clot in the heart is called a heart attack, and a clot in the brain is called a stroke, and a clot in the lung is called a pulmonary embolism. So here's 20 supplements that help protect against clotting. And again, I've outlined the top 3. The third one is a Japanese supplement, which I take personally. So anyway, that's your take-home message. I want to introduce Bobby Chomik at the end. She had both knees replaced maybe 6 months apart. She was on the multimodal program, never took any anti-inflammatories. Aaron Baum, ACL reconstruction. He could tell you his story, not only with him, and he probably took hardly any narcotics and didn't need them, but he has stories like Nick Slenker does of athletes that were started down this road of a sports-related injury, narcotics that led to heroin. It's unbelievable, and I may have them give a 30-minute summary and then open it up for questions. And Bud too, as I said, Bud, ran so much he wore his knee bald, so he had no cartilage. So we did a primitive operation where we drill holes called microfracture. We actually fracture the bone and try to get stem cells to fill it in, and then we inject calcium like cement under a collapsing sidewalk, and all that stuff hurts. And so we told Bud it wasn't going to hurt too much, and he pretty much listened, except for one day he told me it did hurt. But that's the whole deal. So we're not mean. We give you some some breakthrough medication, and but Nick did a great job in talking about the opioids in athletes, if anybody has questions about that. And then Bruce Nicholson really, again, has done a lot more research than I did on the medical cannabis. So Nick takes care of Lafayette, Parkland High School. He was part of the Lakers organization in his training, and he helps take care of the Phantoms downtown. So Nick, I'd just like to ask how he's changed treating athletes and what he's seen in his career with opioids and athletes.
Thanks, Tom. Similar to what Tom was saying, I got involved in this over the past few years at the behest of Dr. Meade, and looking into it, it's truly looking at the opioid epidemic that we're facing now. It's jaw-dropping when you look at the numbers, and it really like in our training you come through and it just we don't really get the focus, at least as when I came through, about what the the downsides are of it. And I think that is changing. So I think the medical community is waking up to it. But you see, the problem itself is also it's become a habit for us. And then it's also been you look at the money behind it. The pharmaceutical companies, like Tom was saying, is that the narcotic medications now it's the second leading pharmaceutical drug in the world behind cancer medications as far as a moneymaker. So it's something on the order of like a $24 billion business when you look at it. And when you look at this business, in America we have about 5% of the world's population, and we consume about 80% of the world's opioids, which is staggering. And obviously we don't have 80% of the world's pain. And you look at that, and a lot of it is, our perceptions. And you look at other countries, and even in Europe, and places where they're doing surgery very similar to us, they have different expectations. They have expectations that you'll get narcotic medications in the hospital for terrible car accident, possibly end-of-life situations, but it's not something that you're going to leave the hospital with. Yet here in America, it's sort of, our expectations have become, any bits of pain, you go to the doctor, and it's just expected that he's going to write you a strong pain medication. And it's on both sides, I think, definitely on the physician as well as on the consumer. And, so I think we've gotten ourselves into this problem. And really, the first step is in recognizing it. And so, I'm really grateful in, being able to work with Tom, because looking at his program, has really revolutionized my practice as well, backing away from narcotic medications. And, as he said, I take care of maybe a younger subset. I specialize in sports medicine. So I see a lot of younger athletes. And, athletics, and I'm a huge proponent of what athletics can do as far as the positive benefits, in a young person's life. But unfortunately, athletics can also be sort of a gateway into injury and pain. And so sometimes that can be a kid's first time where they're dealing with a doctor. They end up getting a pain prescription. And, we see in, obviously the professional levels, it's a major problem. In the NFL, you see lawsuits now against the NFL, and really, like, at the heart of some of those lawsuits have to do with painkiller abuse, and what it's doing to these guys in their, the post-year, after their careers are over. But for younger athletes, it's really all down the line, because I've seen the problem happen with the younger athletes as well. And, just like the stories we hear, it can be innocuous as it starts. A bad ankle sprain. Someone gets a narcotic medication to get them back on the field, and then it can just start the ball rolling. So it's something I'm really hesitant to start. And then really in my practice, doing a lot of arthroscopy, I've started this multimodal treatment program, which has just dramatically changed my practice. And it's really, if you prepare the patient, you sit down and spend a little time with them, talk to them about what your expectations are, and not that you can't ever use a narcotic, but you frame it in the right way, and it's just really successful outcomes, and people are really happier on the backside.
So finally, I'm going to have Dr. Nicholson. So Nick and I cause pain as surgeons, and then Bruce has to treat them. But he's probably the most difficult profession, I think, in medicine and pain management, because it's such an enigma. It's something that he understands better than we do, and it's why I think Bruce could comment a little bit on any potential new aspects of pain medicine, especially the CBDs and cannabinoids that have been around forever, and all of a sudden we're just finding their medicinal value, and not but it's really been used, Bruce, I guess, for thousands of years. But I'll stop there and let you comment a little bit.
First, I'd just like to reinforce some of the comments that have been made so far in regard to the need for quality pain management when we talk about perioperatively. And without question, Tom, Nick, you guys are on the cutting edge. And, if you look at what's gone on in the transition, my training initially was in emergency medicine, and then I went back and did an anesthesia residency and especially training in pain medicine at University of Virginia. In the last 25 years, that's what I've done, is both acute and chronic pain management as well as anesthesia. Over this period of time, it's interesting the transition I've seen and the demand on how the system will respond to individuals and their expectations. And what I mean about that is, we had a period of time where people expected to have pain after surgery because we didn't have good modalities to treat. And people said, oh, well, somebody's going to do something to me, I expect to have pain. Then we sort of transitioned into the 90s, and we had this overwhelming focus on no pain at all. No one should have pain anytime they're in the hospital, and we transitioned into a society of pill takers, and that's why we consume 80% of all the opioids in the world, because we developed this mindset that the only way that we could treat pain was by using opioids. And for a while that was true, but as Dr. Meade has shown tonight, there are a lot of very effective ways to treat acute pain that don't require significant amounts of opioids. And in the anesthesia literature, we've developed tremendous expertise in what's called multimodal approaches, just what you've heard tonight. patients going into surgery, and I will say he operated on me as well. Very similar surgery that Bud had, but I had the benefit of understanding before I went into surgery how I could actually preempt, in a sense, the amount of pain that I was going to have and control it. So prior to surgery, I actually, for 2 days before I had surgery, Tom operated on me, I took Celebrex, which is a potent anti-inflammatory, but has no effect on bleeding, which actually decreases the amount of inflammation after surgery. And every time you injure tissue, you develop inflammation. Inflammation then results in pain, actually. So I looked at that, and I looked at the literature and said, hey, this is a good way to treat this. So you use anti-inflammatories prior to surgery. I said, what Tom talked about, gabapentinoids, Lyrica, and Neurontin. We know that those have effects on not on inflammation, but pain. Actually, once you develop pain, it actually dampens the nervous system. So I actually preloaded with these before I had surgery. After surgery, I literally took no opioids at all. I took just some extra strength related Tylenol, acetaminophen, and some ibuprofen, but needed nothing at all, simply because I recognized that there were ways to do that. So I think as patients, you need to demand that no matter what type of surgery you have, you need to have good pain management, but you also need to demand that it be done in a fashion that doesn't expose you to the risk of opioids. And the risk of opioids are not only the fact that, oh, you may become addicted, highly unlikely for most people, but it can happen, and we know that, and that's a road to that we don't want to go down. But more importantly are the side effects, delayed hospital discharge, nausea, vomiting, all kinds of things that delay your recovery. But there are ways that you've heard tonight that can absolutely change that paradigm and improve outcomes. And we know that the number one cause of a failed knee replacement is not what these guys do, but it's the pain you have in the perioperative period. The pain going into the surgery and the pain you have after surgery are the cause for it, and the changes in your nervous system. It's not, and I can tell you how many times I see patients that have had knee replacements. They'll come in and say, oh, my surgeon did a terrible job. I still have pain afterwards. I said, well, how much pain did you have before? I had terrible pain before surgery. I said, so you have the same pain now? And they say, yeah. And you look at the joint replacement is perfect. But what happened was the surgeon didn't take into account the fact that they had to treat that pain prior to surgery and then after surgery. And they said, well, he gave me lots of opioids. That doesn't help. That doesn't work. We have to do things like these guys are talking about, using local anesthetic, using things like Neurontin, using things like anti-inflammatories, all these different ways that you can change the way the nervous system works, rather than giving people lots of opioids, which really don't. They actually amplify pain. They don't decrease pain in the perioperative period. And that's really, when we look at this, and Tom asked me just, so that's my take home from the standpoint of you need to demand good pain care, but you need to also say and challenge your surgeons when you have an operation to not use opioids. Use multimodal. Challenge the anesthesiologist. When you sit down and you talk to the anesthesiologist, they say, well, what are you going to use to treat me in the perioperative period? They say, oh, we're just going to put you to sleep and wake you up. Not enough. You have to say, what kinds of nerve blocks are you going to use to actually block those receptors that are inducing that painful stimulus to the spinal cord and the brain? Are you going to give me something for the next 48 hours? Are you going to operate on my shoulder, do a rotator cuff repair? Are you going to give me a catheter that actually will give me medication to treat the pain so I don't have to take opioids for 48 hours? There are lots of great therapies out there, interventions that you can use that don't require opioid therapy and can improve your outcomes dramatically. Tom asked me to talk a little bit about cannabinoids, or what are called for generic terms, CBDs. Most of us, when we talk about this, think about marijuana from the 1960s. As Tom's already mentioned, we have receptors in our body. The most proliferative receptors in our entire body are receptors that respond to the constituents of the marijuana plant and the hemp plant, and those are what are called cannabinoids. And I would urge you all to, when you get home, Google what are called CBDs and take a look at them. There's a tremendous amount of literature that suggests that this particular part of our nervous system has been underappreciated and underutilized in medicine in order to take care of a lot of the different conditions, particularly pain and anxiety, which are very common, and we see them quite often in acute as well as chronic pain conditions that go hand in hand. And you can modulate these systems by treating them with certain types of substances that can be extracted from the hemp plant as well as the marijuana plant. It's a fascinating history that goes back 3,000 years to the ancient Chinese literature. And ancient Chinese culture actually used the cannabinoids in the form of hemp as well as marijuana plant to treat pain, all kinds of different types of nervous system problems, anxiety, depression, and they've been used. They were used extensively up until the 1930s in the United States, and the American Medical Association actually considered them one of the cornerstones of treatment of a lot of central neurologic conditions, including epilepsy. And then for political reasons in the 1930s, they became a banned substance for the treatment of any type of condition. And now there's a groundswell and a turning around, and 29 states out of the 50 states have approved the use of marijuana for the treatment. I prefer to call it cannabis rather than marijuana. Cannabis for the treatment of different types of conditions, including in Pennsylvania, chronic pain, epilepsy, autism, all kinds of central nervous system, depression, PTSD, in a very safe fashion. As you heard, there's, as far as safety goes, this system is one of the most unique systems in our body that you can activate it and you can alter different types of things that go on in your nervous system as well as peripherally outside the nervous system in regards to inflammation without having any adverse effects, with the exception of some lightheadedness, depending on what the percent of what's called the THC CBDs are. But there's never been a death reported worldwide related to this particular system. And so therefore we are beginning to understand that it's a safe system, but we also are beginning to understand that it has some very important therapeutic values. One of these are the endocannabinoids are 20 times more potent than aspirin as anti-inflammatories, with no effect on the kidneys, no effect on the heart. And the estimates are in the United States that somewhere between 16 and 20,000 Americans die every year from complications related to our traditional anti-inflammatories. And now that they're pushing back on opioids, more and more people are using anti-inflammatories like Aleve and ibuprofen or Motrin. And we know that these, in the long run, may contribute to increased numbers of deaths and complications related to cardiovascular disease as well as kidney disease. So I think we're on the forefront with some exciting new opportunities to treat a number of different conditions. And Pennsylvania is really on the forefront for opportunities, really.
So anytime you make an incision, whether it's arthroscopic or endoscopic, there's going to be a scar. And so the question is, years ago they were really into making these really small scars, and you can, in a lab, you can do a total knee replacement through a 2 or 3 inch incision. They made special instruments. The problem is it took 3 times as long, and the failure rate at 3 years was tremendous. So it's like building a ship in a bottle. You can do it, but it takes a lot more work than doing it on the bench. So the goal is to make the smallest incision to do a perfect job. And whether you make that in the front or on the side makes no difference on how it looks. But we try never to put it right in the front, because then when you kneel on it, the scar can hurt. But most of the knees we put in today, you can kneel on. You can kneel on the prosthesis. It doesn't mean the scar will be comfortable, but you always want to move it off to the side. But there's little tiny people and there's big people, and you have to make the right size incision to get into that joint and do a good job. Think of the knee as 3 joints, not 1 joint. You have the inside part, the outside part, and the kneecap. So there's 3 parts. Well, actually, total knee replacements started with partial knee replacements 50 years ago, where they would just put a partial crown on one side. And then when the other part of the knee wore out, they put another partial crown. And then they said, why don't we just weld this together and make one crown? And then so for years, it became a total knee replacement. And then we sort of regressed back, and we got better at the partials. So now about 10% of all joint replacements are a partial knee replacement, where if half of the knee is worn out because you're bow-legged and the outside is normal, like your shoes. You know how you wear one side of the heel out and not the other? It looks like you never walked on it. Well, there's knees that look like that too. It looks like you never walked on the outside and your kneecap is okay, so you can do a partial. But really, the incision isn't much different, and it's the same. We sort of have always done partial knee replacements. I have as an outpatient, but now we've gone to be able to use that same technique, small incision on the totals, and send them home the same day. But it is a little less invasive just because you don't have to get to both sides of the knee, if you will. And right in front of you, there was a question. We think that will change in the next 12 to 18 months. There's a code. If you're a Medicare patient and you need a partial knee replacement, they recognize that. If you're the same patient and your whole knee is worn out, they don't recognize that as an outpatient. There is no code right now. So it's kind of crazy, and they're working on it, but it'll get there. So Bobby Chomek, if she was Medicare instead of commercial insurance, she could not be home by 10 in the morning. It's crazy. Even though it's safer for her, get out of the hospital. She has no risk now of hospital-related, complications. But it's sort of a hot issue now with the new administration. And there was another question over here. Yeah. Always, because remember the problem is it's hard to do. Because most people, will say, it hurts too much to exercise and lose weight. But every pound you lose before surgery, if you're overweight, is 4 pounds off your knee. And I always say it's 80% nutrition, 20% exercise. And exercise is good if you use common sense. But if you say, I'm going to go to the gym and start squats, leg extensions, lunges, and start running with Bud, it's not going to work. You're going to be miserable. Your knees are going to swell up. So I say it's common sense. You want to stay active. You want to do things that don't hurt. If your arms don't hurt, you do upper extremity exercises. You want to stay active, get in a pool, stationary bike, anything that's moderate that doesn't hurt. But obviously, if you could lose weight and be in the best shape you can, that's to your advantage. So the good thing about coordinated health is we are not a resident teaching program where Nick and I trained, it's at Jefferson. We got to do a lot of surgery when we were residents there, so that's the trade-off. But here, we don't have residents, so I do 100% of the surgery. My team is I have 3 PAs. I make the incision, I do the whole operation. I close everything but the skin, and they are much better than closing the skin at me. So I have patients come in and ask for one of my PAs because they close the skin better and they take their time. But other than that, I do the whole operation. So I want to thank everybody, especially the panel, the audience, for coming. Time is such a valuable commodity. We only have a limited amount of that in our life. So for you to come here and invest and listen to us, I can't tell you how much I want to thank you. I really appreciate it. Have a good night.